Good evening and welcome to tonight's program titled Sleep and Autism. My name is Dr. Susan Brasher, and I'm the program chair with the Atlanta Autism Consortium's Board of Directors. The Atlanta Autism Consortium is a nonprofit organization dedicated to creating collaborative conversations throughout the Metro Atlanta autism community and beyond. We host free programs just like this on a wide variety of topics and are so glad you've joined us tonight. Before we get started, we have just a few reminders. As an attendee, your microphone and camera will remain muted, but you can ask questions you have throughout the program in the chat by clicking on the chat at the bottom of your screen. We also have time at the end of the program to fully address all of your questions. And then we'll also be mailing out the contact information for our panelists to the email address you registered for this program so that you can contact them directly with any further questions you might have. Tonight, we are joined by Dr. Beth Malow. Dr. Beth Malow is a professor of neurology and pediatrics, the Burry Chair in Cognitive Childhood Development, and the director of the Vanderbilt Sleep Division and Vanderbilt Sleep Core. After completing a combined undergraduate and medical school program at Northwestern University, she served as a neurology resident in the Harvard Longwood program and as a fellow in clinical neurophysiology at the National Institutes of Health. She was previously faculty at the University of Michigan before coming to Vanderbilt in 2003. Dr. Mallow's clinical, educational, and research programs focus on the impact of sleep disturbances on autism and related disorders of neurodevelopment. With that, I want to welcome my colleague, Dr. Malow, to the Atlanta Autism Consortium Sleep and Autism Program.
Thank you, Susan. It's such a pleasure to be here tonight and to speak to you all. I just want to make sure you can see my slides in slide mode. Excellent. Well, welcome, everyone. Thank you so much for taking the time out of your day to come. My passion is sleep and autism. I just wanted to add to what Susan said that I have two adult sons on the autism spectrum. They both had challenges sleeping. Fortunately, I was a sleep specialist. I also think I learned as much from them as hopefully they learned from me. And I hope to impart some of my knowledge and wisdom to you all tonight. What I'm going to be doing is, first of all, mentioning that I do have a couple of disclosures. I am consulting for Neuron Pharmaceuticals. They have an extended release melatonin product that I may bring up later, especially in the Q&A. So I wanted to mention that. And then there are no approved medicines for sleep and autism, especially in kids. So I will be discussing off-label uses of approved medicines for other things, and we may get into that as well. What I'd like to address in the next hour, I'll speak for about 30, 35 minutes, and then we can take your questions, is what are the causes and contributors to sleep problems in children with autism, children and teens? What's the impact on the child at school, at home? And what treatments work, not just medications, but behavioral treatments, approaches to co-occurring conditions, all of those kinds of things. So hopefully we'll get those questions answered for you. And I am a clinician as well as a researcher. So I always like to start with a case. And this is the case of Alex. Alex is 10. He has autism, ADHD, epilepsy, and anxiety. So he has a lot going on. And he goes to bed at 8 p.m., takes hours to fall asleep. His parents say he can't shut his brain down. It just goes and goes and goes. And he takes methylphenidate, Ritalin, in the morning and afternoon for his ADHD, takes Lamictal, lamotrigine at night for seizures. And he also enjoys a glass of Mountain Dew with dinner. He plays video games after dinner, and he just can't settle down to go to sleep. He'll keep going up and down, finding his parents. They bring him back to his room. They rub his back. And then once he falls asleep, he awakens multiple times during the night. Sometimes he comes to his parents' bedroom, falls asleep there. He snores in his sleep, and he's very restless with frequent leg kicks. And it's very, very hard to wake him up in the morning for school. He's described by his teacher at school as being sleepy and hyperactive. And his parents, as you can imagine, are exhausted and very overwhelmed. So if we were in person, I'd be asking you to think of all the things that could be going on with Alex's sleep. So I hope you'll just think through those. There's a bunch of things here, and we'll go through those on a couple of slides. But I want you to just take a moment and look at and reflect on what I presented and think about how could you help Alex? You know, one or two things that maybe stick out at you in his case, and we'll get to those in a moment. The other thing I want to mention is taking out his tonsils and adenoids didn't solve the problem. It resolved his snoring and it improved his seizures, treating his sleep apnea because he had turned out to have sleep apnea on a sleep study. But he's still taking an hour to fall asleep and he still wakes up at least once a night and he continues to be restless in his sleep. So the question becomes, what do we do next? And this is where I really enjoy this work so much because contributors to sleep problems and autism are layered. They're multifactorial. You really just have to dig in and listen to families, hear where they're coming from, and try to figure out what bucket the sleep problems are in. I like to think about biological, medical, and behavioral. They're simplistic, but they are easy for families to follow. So when I think about biological, I think about arousal dysregulation, being, as I said, feeling like you can't shut your brain down, or melatonin processing, how we use melatonin in our bodies, the melatonin that we make ourselves, or genetics, the genes that go with sleep and autism and insomnia, melatonin genes. And then there's a category called medical. This is where sleep apnea fits in. This is where reflux fits in. This is where seizures can fit in. This is where doing a sleep study can fit in to try to detect what might be going on. And where a lot of those medicines, like the ADHD meds that I mentioned, or the lamotrigine, could cause poor sleep through being too stimulating. Some meds are sedating, which can help sleep. So that's that whole medical category. And then the behavioral category. This is really interesting because a lot of people will say to me, well, kids with autism don't respond to behavioral treatments. They don't respond to routines. And I'm like, yeah, they do. In fact, sometimes they respond better to routines than kids who are typically developing because they oftentimes have transition difficulties. And if you can transition them through a bedtime routine or put something in place like a bedtime routine, you're going to wash your hair and you're going to take your bath and you're going to use the bathroom and you're going to read a book and a story and then you're going to say goodnight. That actually can be very relaxing for the kids. And they crave that sometimes more than kids of typical development. So I'm a big believer that the behavioral category can be very helpful for these kids. The other thing I want to mention is that as we go through our kid years into our teen years, sleep patterns continue to change. And this is not just in autism, this is in kids with typical development. And I use this a lot when I talk about school start times and the need for making start times later, because what happens when we go from being elementary school to being high school, there's this pattern of sleep and alertness throughout the day. And it's shifted. These are the same curves, and they're shifted by about 2 hours in the high school student compared to the elementary school student. And that happens with puberty. So if you look here, like at the elementary school student, they're alert during the day, and then they get sleepy at night. And then this is showing that when they wake up in the morning, they're alert again. But there's this forbidden zone for sleep around 8 o'clock at night. They're just not ready to go to sleep. It's harder to go to sleep an hour before we're ready to go to bed than any other time during the day. And then they drop off and they fall asleep. And then here it is, 7:30 in the morning, and they're ready, bright and ready for school. So the high school students, their forbidden zone is pushed out later, 2 hours on average. But in some kids, it can be after midnight. And they're definitely not ready to start school at 7:30 like the younger ones. That's where moving schools later for teens is getting so much press and so much attention. But the point I want to make on the slide is there really is a biological reason why it takes us longer to fall asleep, or we have to go to sleep later when we're older. And it's a combination of a delayed release of our melatonin and also slower buildup of sleep promoting substances like adenosine in our brains and bodies. And fortunately, that delay improves in adulthood, but a lot of teenagers, especially those with autism, sometimes really struggle to fall asleep and be able to get to school the next day. Practice pathways. I wanted to just mention that little triangle I showed you, the biological, the medical, the behavioral. This fits in really well with how we want to practice sleep and how we really want to get pediatricians to screen for sleep, pediatric nurse practitioners. The idea of screening for sleep problems as part of a child's well exams, identifying medical co-occurring conditions when they're there, doing sleep studies for sleep apnea if needed. And we've put together these brochures for people, for kids who need extra support and help. Starting with behavioral strategies, that's that little blue box here, if the family is willing and able to implement them. And remembering that medicines can play a role, but we want to use them sparingly to facilitate behavioral strategies. And using medicines that treat co-occurring conditions like seizures, like ADHD, and using low doses. And then we also want to emphasize how important sleep is for emotional regulation, behavior, and core symptoms in autism. So I used to just think when I haven't slept well, I feel like I'm more irritable. I want to be careful not to send that email I'll regret later, or that post. I guess we used to call them tweets, now they're posts. And I've realized over time there is a literature showing that that idea that when we sleep poorly, we're less regulated, we're more dysregulated emotionally is true. There have been imaging studies using brain imaging. It's called functional MRI, where you can go in a scanner, and sleep loss actually increases activity in fear centers in the brain, like the amygdala, like the front of the brain that clicks in with the amygdala and controls it and kind of keeps it in check. So all of that is affected by not getting enough sleep. And it's true, when we don't get enough sleep, we're more grumpy, grouchy, apt to fly off the handle. Think about our kids with autism, our teens with autism, who are even more susceptible to that. And it's kind of like the perfect storm. So really focusing on sleep, not only in terms of, if I sleep better, I'm going to have better health, I'm going to have better weight management, I'm going to have better heart function, all of that, but also our emotions are affected by sleep. The other thing is behavior and core symptoms. So in a study of more than 2,700 children, this was a Simon Simplex genetic study, core symptoms were more severe in the kids who were sleeping less than 7 hours a night, or 7 hours or less a night. And then Micah Mazurek and Kristen Soul looked at night wakings and other sleep problems, and they found that they were significantly associated with physical aggression, irritability, inattention, and hyperactivity. So there's definitely a connection that goes beyond sleep is good for health and gets into how we feel, how we behave, even the family, how the family functions. If the family is waking up, the parents are waking up at 3 a.m, they're going to be more stressed. They're going to be less able to be a good caregiver for their kids. So that brings me to treatment. And this is the really fun part. We know that treating insomnia works. We can train parents of kids with autism and teach them how to help their kids sleep better. The challenge is, and as I said, the really fun part for me is, how do we translate this into our practice? And how do we deliver and motivate parents? And if it's a really busy practice, how do we do it? Pediatricians have to do so much. They have so much on their plates. pediatric nurse practitioners, there's vaccines, and there's guns, and there's all sorts of things they have to talk about these days. How do we get them to implement treatment for insomnia in autism? And this is where I'm super excited to be working with Susan, because one of Dr. Brasher's interests is patient-centered work and patient-centered approach. And this is something that I think is so critical to sleep, because what we're trying to do is really focus on the needs of the family. So I always start with a sleep hygiene, sleep habits 12-point questionnaire that you can give families. They can fill it out, they can bring it to the clinic, or they could fill it out in the waiting room. And it doesn't just ask about what happens at night, it asks about caffeine and exercise during the day, how much light they're getting, what they're doing at night, what the environment looks like, what the bedtime routine is like, are there cell phones involved? And you can use this, and we've published this called the Family Inventory of Sleep Habits, to kind of gauge how well a family is doing with sleep in their kids, and even things like the interactions with the parents. Do the parents stay in the room until the child falls asleep? Sounds like a great idea, but then if the parent wakes up in the middle of the night, I'm sorry, the child wakes up in the middle of the night and the parent isn't there anymore because they've left, they're going to have a full-blown night waking. And while if the parent allows the child to fall asleep on their own and gradually leaves the room, it can make a huge difference in the child just sort of waking up, rolling over, and going back to sleep. So different things like that are what we use. And then we go through in our therapies, in our programs, the importance of exercise and light and caffeine, limiting naps, not using the bedroom for timeout, but really using it for selectively in a way that promotes sleep and good sleep habits. Limiting stimulating activities toward bedtime, limiting light, implementing routines, making sure that the environment is good. This is where the patient-centered approach really comes in well. My son did not want the dark room, the no noises. He wanted a night light. He wanted the door left open so he could hear the sounds from the whole house, because that way he was less anxious because he could hear us and he knew we were there. So every kid's a little bit different. Bedtime routines, as I mentioned, the kids with autism crave these, whether they're line drawings or checklists. There's something about moving these icons around and checking things off that really appeals to them, and they just love it. And it gives them that structure to get through the routine and transition to sleep. And then we spend a lot of time with parents. Parents of kids with disabilities are not really fond about having their child in the room, leaving the room, letting their child cry themselves to sleep. It's just not very accepted. And I don't blame them. I mean, it might work for typically developing children, but a lot of parents of kids with autism have not found it very successful. The kids don't know what's going on, what's supposed to be happening. What we find instead is to do like a more kinder, gentler, gradual, we call it gradual extinction, if you like that term, extinction, which is kind of extinguishing these habits. What we do is we say, find a really comfortable chair, maybe a rocking chair, maybe just a comfortable chair, sit in the chair, read a book, read a magazine. Your back is to the child, or at least you're turned away from the child, so you're not making this one-on-one eye contact. You're not having a party with your child, but they know you're there. They're comforted. And then move the chair closer to the door every night until you're out of the room, and couple it with presents. You know, morning stickers or a basket of presents from the dollar store that are all wrapped, and your child can pick one up when you successfully get them, when they successfully can sleep through the night without you there. I mentioned this earlier, the idea of if the parent's there when the child's falling asleep and then the child wakes up, and we all wake up during the night, the child will have more trouble getting back to sleep if the parent's not there in the middle of the night. So helping children fall asleep on their own, comforting them, but letting them finish the process of falling asleep, because a child who can fall asleep on his or her own can go back to sleep on their own. Watching out for items like you that the child may become dependent on to fall asleep. and aren't there when they wake up. So it's kind of like the pacifier that falls out of the infant's mouth and then they cry because they don't have it anymore. So don't become a pacifier for your child. Like find ways to comfort them, but then leave the room and let them finish the process on their own. I mentioned also the parents respond quickly to distress. Sometimes people will have a camera in the room or a nanny cam, comfort, reassure, but really brief interactions. Try not to over respond. And you can do things like use visual reminders, stop signs on the door, different things that can help children remember to stay in bed and choose realistic goals and rewards. Like, let's do a sticker for each night that I can stay in my bed. And then when you get 4 stickers or 5 stickers, you get a reward. Love the bedtime pass. It's a guy named Fryman developed it for typically developing kids, and we adapted it in our work for autism, specifically the kids who used to be called Asperger's. Now everybody uses ASD, but you know what I'm talking about, kids who have that sense of control, that strong sense of control and autonomy. And the idea is that you give them this laminated card and you find something that appeals to them. It might be a TV character, it might be a moon and stars, might be an animal. And they hold this. This is their pass. It's like their ticket. They can keep it all night and trade it in for a reward in the morning, like a wrap present from the dollar store. Or if they need it in the middle of the night, if they need a hug, if they need a glass of water, it's their decision. They can turn it in for whatever they need from mom or dad. But if they don't turn it in, they can save it. And in the morning, they can get a reward. So they're in the driver's seat. And it helped my younger son a great deal. He was very anxious and he knew he could hold on to this pass and use it if he needed it. But if he didn't need it, he would get a reward in the morning. And we put together a little story that went along with it. And it talks about the importance of sleep. And my parents want me to get a good night's sleep. And it explains the pass. And we've had a lot of success with this strategy. And this is just one of the things. If you want to use your phone, there's a QR code there. You can take a picture. It's and we'll send this out as well. Autism Treatment Network has done a really great job with visuals. I was able to help them put together visuals for visual schedules, visuals for bedtime passes. We have sleep strategy for teens, street strategies for kids. So that's all free and easily downloadable. And then the other thing I wanted to present was I have written a book with a colleague of mine in Colorado named Terry Katz. We wrote this book for parents because we wanted parents to be able to have a do-it-yourselfer where they could learn to teach their kids to sleep on their own if they didn't have anything available in their communities. So we went ahead and put that together. So these are all resources that you can find the book on Amazon that you can access. And this is something that led us at Vanderbilt back in 2014, or actually, I guess a year or two earlier than that. We published it in 2014 to do a sleep education multi-center trial in which we enrolled initially, we enrolled kids and parents of kids with autism who are taking 30 minutes or more to fall asleep on 3 or more nights a week. And we gave them a pamphlet to read. That was it. We gave them a pamphlet. But then we also did a different intervention where we randomized them to work with an educator who would go over bedtime routine, daytime habits, interactions, and teach it to them in a structured way, and then follow up with them at week 5 and 6 with a brief follow-up to see how they were doing and continue to support them. And we did it in a group as well as an individualized session. And then we looked at sleep and behavioral measures at baseline and 1 month post-treatment. And what we found, this graph is showing sleep latency, which is time to fall asleep based on actigraphy. So think of it as the Fitbit or the Apple Watch, and you can measure how long it takes you to fall asleep. Well, the kids who got either no treatment or the pamphlet did not have a significant improvement in their time to fall asleep. The ones who got no treatment actually got worse. The ones who got the pamphlet got a little better, but not that much better. But if they had the coach, if they had somebody coaching them through, as I said, like a 90-minute session with 2 brief follow-ups, we saw an on average improvement in sleep about 20 minutes, a little bit longer than 20 minutes in both groups. And that was pretty neat. I mean, some of the families, it was an hour. They went from taking 2 hours to fall asleep to 1 hour to fall asleep. So it was really impressive. But these significantly improved their sleep. And we didn't see a big difference between the individual and the group. So whether they got it in a group or whether they got the support one-on-one, they both did well. And we also saw improvement on questionnaires, on some core symptoms like repetitive behavior, child behavior, pediatric quality of life, and even how confident the parents felt as parents, how much efficacy and satisfaction they got out of being a parent. And it makes sense. Like if you give a child a medication, they may not have that same level of efficacy as if you're giving your child an a behavioral strategy that you're helping them implement. So that was all very satisfying. We are now moving the strategy into community practices. We published in 2021 on this ability to get pediatricians and pediatric nurse practitioners to work with parents. And the way we did it, since those practices, as I said, are so busy, is we said, identify kids who need help, identify families who need help with sleep, make sure they don't have apnea, seizures, reflux, some other medical thing going on, manage that, and then make a referral to a community therapist. And we had these community therapists trained. We trained them. We trained speech, OT, behavioral therapists in the community. They partnered with the pediatric practices, and we taught them how to deliver behavioral sleep education, just like we had in that study I just showed you, which was done more in academic centers. We taught therapists who knew about autism but didn't know very much about sleep how to deliver the sleep intervention. And we went over the fidelity, we had them videotape, we went over everything. They were very excited about the new skill. The parents were very excited to work with them. They felt like these were therapists who knew their child, who knew autism, and they were very satisfied with it. And the good news is just about every community has a therapist. So they don't have to drive. The parents don't have to drive to, like, behind me, you see Vanderbilt Medical Center. And in Tennessee, parents sometimes have to drive 2 or 3 hours to come here. This way they could get their community therapy, and it was a lot easier and simpler. So we are now, Susan and I are now working on disseminating this community study, even more widespread, scaling it up. We're going to be doing it in Tennessee, in Colorado, and in Atlanta. And if you're interested, if you know people are interested, if you yourself might have a child on the spectrum and you're interested, you can just email me at beth.mallow@bumc.org. And we will, once we start recruiting, which will be later this year, we can get you the information so that you can benefit from this study in Atlanta. And I just wanted to conclude before I take questions. Not everyone benefits from behavioral sleep intervention. Some people need something more. And a lot of times that more thing is a parent is so stressed or a child is so stressed that they're unable to calm themselves down to do the bedtime routine, do the behavioral intervention. So what we've done is explored this idea of using supplemental melatonin. And this is something that's around, we make our own melatonin in our bodies, but I'm talking about the supplements you can buy at the stores, the health food stores, the supermarkets, the drugstores. There is a lot of literature, case studies, randomized trials, reviews, showing that melatonin works. Melatonin in behavioral therapy, of course, is the most effective because you're combining the two. And then I also mentioned earlier this prolonged release sometimes helps more with night wakings because it's got a longer duration of action than the immediate release. So that's in the mix too. And then lots of, and I'm happy to share any of these references, but we'll get the slides to you. What I've realized though throughout the years in terms of using melatonin is there are a lot of questions that parents have about melatonin. It's very confusing when you go out on the websites. You don't know what you're getting. Am I getting a reputable brand? How much should I use? It can be very overwhelming to parents. And one of the things that I want to conclude with is I want to show you a video that I've put together. Again, you can use your phone and take a picture of the QR code. It's a video and it's some blogs, and the blogs are at the end of the video. I reference them, and we'll also get these sent out to you. It's to help families navigate what's out there and make them smarter consumers so that they can work with their doctors and nurse practitioners to figure out if melatonin is right for their child. Some of the questions people have asked me are, will my child become dependent on melatonin? How do I choose a reputable brand? How much do I give them? So I am going to go ahead and just stop my slides for a moment, and I'm going to go to the video and show you the video. And just the first few minutes, it's really a very brief video, but I just want to give you a sense of it, and then we'll finish the slides and take questions. So let me just do this. Hold on. And I'm going to share my screen again and go to this. And Susan, I'll make sure that you can hear this. Can you hear that?
You know how you feel after a great night's sleep? Refreshed, energetic, and ready to take on the world? Children with autism feel that way too. I'm Dr. Beth. I specialize in sleep medicine with over 20 years of experience. And I'm also a mom. Sleep is a major problem for many children with autism, and it can affect how they behave during the day. Sleep can also affect how they perform in school. How do we help kids with autism sleep better? As a doctor, I make sure there isn't a medical cause for the sleep problem, like stomach problems or seizures. I check in with the parent about caffeine and video games, which can be stimulating and interfere with sleep. I work with parents to put into place a calming bedtime routine. But sometimes a child needs something more to ease them to sleep. You may have heard about melatonin. Melatonin is a natural substance created in our brains to promote sleep. But how does a parent navigate the choice of whether to give their child with autism melatonin? And because melatonin is not a prescribed drug, how do you choose from the overwhelming variety of melatonin products? Melatonin has been baked into brownies and combined with chocolate and CBD. The safest way to give melatonin is to find a brand that only contains melatonin. In my blog, I'll help you figure out side effects, when to give melatonin, how much to give, and more. My goal is to help you work with your doctor to feel more knowledgeable, more empowered, to decide if melatonin is right for your child with autism.
All right, I hope that played okay. Let me go ahead and finish my slides, and then we'll take some questions. All right. So the last thing I wanted to show you is all the different medications that are out there for sleep. And it really is trial and error. This is why I prefer behavioral strategies, because we just don't have the evidence base, apart from melatonin, which doesn't work for everyone, for some of these meds. I will say that I've personally researched gabapentin with my colleague Althea Robinson Shelton at Vanderbilt, and we've had a lot of success with it. And it might also be because it helps restless legs and restless sleep. And then you've probably also heard about clonidine. There's also a medicine called mirtazapine. But other than those, everything else has not been studied. And even those drugs that I bolded here have only been studied in small numbers. So we really need more studies.
Beth, would it be possible to switch your settings? They reverted when you
Oh,
clicked.
they reversed. I'm so sorry. Thank you. Okay, there we go. Is that right now?
Great, thank you.
Okay, great. Thank you, Susan. So to end, I'd like to just mention that sleep problems are common in autism. They can impact daytime functioning. And then once the cause is identified, I really believe we can treat sleep difficulties. Just like that case, Alex. And I know I didn't give you a great answer for what helped him, because so many different things helped him in the end. Paying attention to getting rid of the caffeine and the Mountain Dew, and improving his bedtime routine, and finding relaxing things for him to do at night. All those things make a big difference. And medicines sometimes help. They do have side effects, but sometimes they're appropriate, particularly in helping take the edge off and allowing a child to fall asleep easier so that you can implement a bedtime routine. And then finally, what I'd really love to see, and very much in line with patient-centered research, family-centered research, Susan's work, is this idea of getting input from families as we do these comparison studies of medication and behavioral approaches, so that we can improve sleep in this population, and not only improve sleep, but make a difference in daytime functioning as well. So I will end there, stop my slides. I hope that was helpful, and I'm really excited about taking some of your questions.
Thank you, Dr. Mallow. That was a great overview. And we do have some really great questions in the chat. I'm happy to read them to you. I'm really interested to hear your responses. The first question was, if a child has an aversion right now to visual schedules that have undesirable tasks like going to school or going to bed, what are some alternatives or ways to warm them up to the idea of a visual schedule?
So in other words, if they have an aversion and they just don't want to do the schedule or something.
Right. Or just looking at the schedule and seeing the go to bed or go to school makes them not want to do the schedule at all. What are some ways that we could work around that?
That's a really great point. I think one of the things that I'm really big on is the autonomy. So we actually order the schedule. I didn't get into this, but we've developed a checklist and a check sheet that gives parents a chance to work with the child and say, what are some activities that you like to do? So for example, the child may love the bath and really enjoy that. And there may be some other things that they're adverse to doing, like brushing their teeth. So that's where we're going to brush the teeth first and then do the bath, versus the other way around, so that they do the negative thing first, knowing they're then going to get the positive thing. It's hard to struggle with if they don't want to go to bed. I agree. But there's also if we go to bed now, in the morning, we can watch my favorite, their favorite video. So we'll have a first sleep, then you wake up and you can watch whatever the video is, and you could put the name of the show on it or whatever. And then giving them choices. Do you want to read a book? Do you want to play with Legos? Do you want to color? Giving them that autonomy, I think, goes a long way. So those are some of the things that we try to do.
That's great. Thank you. Another really great question, and I love where this person's coming from, is what are considered reasonable accommodations for an IEP or an individualized education plan for a child with severe sleep disorder? So they have severe disrupted sleep that obviously affects their daytime behavior and their school performance. And so what can parents reasonably ask in an IEP?
Great question. One thing that I think we can do a lot with is bedtime and wake time. I brought that up with the teenagers, but even some kids who are 6 or 7 have a delayed bedtime. And we find that when we delay bedtime, it sometimes can promote sleep. It's one of the most positive things I've seen for trying to promote sleep. So unfortunately, our schools start so early that parents oftentimes will put their child to bed at 8 o'clock and they're in the forbidden zone, right? That I mentioned, and they maybe have limited verbal skills. They can't even express that they're not ready to go to sleep. So what we can do with the school is we can say, can we get a later bed? Can we get a later start time? I mean, probably gonna have to drive your child in rather than the bus being able to take them, but still, can we allow the child to show up at school at 8:30 or 9 if they're a teenager, or maybe, depending on what their school is and when their school starts. Or could we make study period if they're in high school? Could we make study period first period so that they can come in a little later? Can they take an online class first period? So that to me is the biggest intervention that I've done throughout the years with kids and school is giving them that. There's also the ability to take a nap during the day if they need to have that nap time. Even if they're a teenager, but the ability to recognize that you have to work with them and work with their schedule and their school. Other things that I think can make a difference are probably more general and not even go beyond sleep, like the ability to take some sensory breaks, because that can help them, or exercise if they're getting sleepy, and being able to just get up and walk around can make a big difference in terms of being alert. So
Those
it
are really
really
great.
individualized. Yeah.
I think those are really great suggestions to build into an IEP depending on the child's age. And so I think those are really great. Another great question was, what do you recommend for a 2-year-old who can't fall asleep until midnight?
It's probably less of a problem for the 2-year-old and it's more of a problem for the parents because they're trying to figure out what to do. If it's a 2-year-old who can't fall asleep until midnight, but then sleeps till 9 o'clock in the morning, it's a different situation than a 2-year-old who falls asleep at midnight and is up at 4 a.m. ready to go. So that's the first question I would ask.
Mhm.
I'll give you answers to both of them. The one who goes to bed at midnight and sleeps till 9, you can do some strategic things to just kind of move things back. I mean, the first question you have to ask yourself is, do I even need to change it right now? If the mom or dad is at home and they can move their schedule around to go to bed at midnight and wake up at 9, it may be fine just to go with that. But if they need to get the rest of the family on schedule, they've got older kids who have to get to school or whatever, you can be really strategic. I'm a big believer. Again, I think melatonin is safe, but I would probably start with light. I would start with waking up the child at 7 or 8 a.m., probably 8 a.m., and get them exposed to bright light because that's going to make them more tired and able to go to bed like at 11 o'clock at night. So then you could do 8 a.m. to 11 p.m. and then you can basically back it up. Then you could do 7:30 in the morning till 10:30. So just very gradual improvement in the time that they go to sleep. And that bright light in the morning will synchronize their clocks and make it easier to go to sleep at night.
That's
That's how I would handle the midnight to 8 a.m. Now or 9 a.m. The midnight to 4 a.m. is a lot harder.
Mhm.
I have tried throughout the years to get kids to sleep longer. I've tried gabapentin, for example. I've tried different drugs, melatonin. It doesn't always work. I mean, what's more successful is trying to figure out if there's something that's waking them up at 4 a.m., like sleep apnea. That's something I would always aggressively look for. Is there something waking up this child after 4 hours of sleep? Because that's important for their health as well as the family. But if there isn't, and you've looked and they've been to the pediatric practice and you've done sleep studies and you can't figure it out, they may truly be a short sleeper. And that's something that is really hard to treat. There are, I'm convinced, kids with autism who just get a certain amount of sleep and they're done. As they get older, they can learn to wake up on their own and entertain themselves with Legos or whatever. But it's one of the toughest things I do, particularly when the parents are and they're younger and they're not safe, and you have to have vigilance. So that's one of the challenges. But I always start with that, like, is it midnight to 4 a.m. or is it midnight to 9 a.m.? Because that's going to affect a lot of how you handle it.
Thank you. That was really helpful. And I'm glad you mentioned teenagers, because the next question is about for teenagers who are trying to exert their independence. How do you suggest continuing to enforce sleep hygiene when teenagers don't want to listen sometimes, right?
Right,
So
right.
how do we get a teenager to actually listen or enforce the sleep hygiene when they often think they know more than us parents?
Yeah, this is not unique to autism, right? I mean,
Right.
it's any kid. I have found you've got this is the family centered again. You've got to figure out what's in it for them. It's not going to work to tell them you need to go to sleep and you need to do this and you need to turn off your phone, and you have to figure out what the payoff is for them. And for many teens, there is a payoff. It may be being able to go out with their friends and not fall asleep, and just it what I found is something about how they want to spend their days, something about how they want to do at school, figuring out what the motivation is for them to feel better. And then that's challenge one. Challenge two is then how do you get them to do it? And I've actually found, going back to what I mentioned earlier with the bright light and the synchronizing, I found, for example, that teenage boys, if they can get on a tennis team or some other athletic thing where they get that light in the morning, they're up and they're motivated by the sports. I mean, girls too, to some extent, although the girls I found over the years, once they have that motivation, they're more willing to do what they need to do with their hygiene, the sleep hygiene. But the boys, getting them on some sort of a team has been the most successful thing that I've seen, because then they're getting up, they're awake, they're getting the light, and that can make a big difference.
Thank you. That was really helpful. There was another question, but I'm waiting to see if we can get a little more information on it. But it asks how, and maybe this was referring to the previous example, but how do you help a 13-year-old whose natural rhythm is a reverse schedule? So maybe by that, and while I'm waiting for them to further elaborate, maybe by reverse schedule, meaning they're up all night and sleep all day. How do you get somebody to transition away from that type of sleep?
Yeah,
Yeah,
it's
that's exactly what she meant. Mhm.
yeah, it's like flipped. How did we get an is it a did we get an age on
It's
the child?
13 and it is
13.
a girl, which I can relate to, working with a lot of girls on the spectrum. I hear this very often on in girls versus the boys, but would love to hear more with girls maybe staying up all night and sleeping all day. And then that
Right.
routine. So how do you break that cycle and get out of that habit?
That's a great question. I mean, again, I would start with first, you've got to motivate them, figure out maybe they want to be with their friends during the day, or they need to do better at school because then they're going to have more success in some area of their lives or whatever, or there's some club or something they really need to be doing during the day. I'm assuming they probably are being homeschooled, right? If they're sleeping during the day and up at night, I've been imagining, but maybe yes, maybe no. But once you figure out that motivation, then the key is I like the idea of kind of moving things gradually. There's actually something called chronotherapy where you might have them stay up, like going in the direction of staying up later works better than going backward because our brains and bodies are on a slightly longer than 24-hour day cycle. So the child who's waking up at somebody who's up all night and then going to bed between, I don't know, 7 in the morning and 4 in the afternoon, if you can get them to stay up, you might even march them around the clock and get them where they're up later and later, and then you finally are hitting that 10 o'clock at night or whatever, and then you got to lock them in so that they don't keep going around the clock again. And the locking in can be done with melatonin. So I would say use this chronotherapy, and don't do this on your own. I feel like the parent is saying don't play with matches on your home. Don't try this at home. This is a tricky one. This you want to do under the guidance of a sleep doctor or a sleep nurse practitioner, because it's complicated and you don't want them to start free running and just continue to go around the clock. But that's the basic principle is you move their bedtime every few days until they're where you want them to be, and then you lock them in with something like melatonin.
And it sounds like that they're usually able to get her onto that schedule during school, but it's the breaks like Christmas break or summer breaks, then the wheels kind of come off and they go back to this reversal. So maybe trying to keep her on that schedule, or like you're saying, if she is going to revert as we're gearing up for school or off of break, to march her around the clock on that chronotherapy. Sounds like.
Yeah, I would say if that was my child, I would be trying when they're on break to not deviate. Unfortunately, a related question is, can my child stay up later on weekends? And I'm like, 2 hours at most. So yes, they can sleep until 9 a.m., but not past that. Yes, they can stay up till 11 p.m., but not past that. So I'm pretty strict about that
Not
stuff.
too big of a deviation on the break. Okay. And then one thing you mentioned with chronotherapy. So to clarify, one of our viewers asked, is that something like the strategies for overcoming jet lag by just staying up until nighttime in the new time zone? So is that similar to the chronotherapy when you use that term? That's what you're referencing?
Yeah, it's very similar. It's not exactly the same because your circadian rhythms are changing when you do the jet lag, but it's the same idea, that you're moving your bedtime around as opposed to using a drug or anything else. Yeah.
Right. I could see how they would draw that similarly to that. And then another question about melatonin, and which you have a paper written on this, so it'll be great to hear about your experience with this. Is it safe to take melatonin 5 milligrams at night, long term, possibly forever?
Great question. I would say, and you guys can read my blog and decide for yourself, but I think it is, as long as it's a reputable brand. And you'll learn in my blogs about something called USP, because we don't have prescription melatonin in this country. I mean, we do, but it's not FDA approved. Like you can get maybe a pharmaceutical grade through your pharmacy. But what people are pretty much doing is going to stores and buying it. And it's like, how do you know? But there is a USP brand that has the manufacturer at least adhere to certain standards like purity and making sure there's not anything else in it and all. So I think it's fairly safe as long as you're not overlooking some medical issue, making sure that the melatonin isn't interacting with some other medicine the child is on. That's why I always say, talk to your doctor, talk to your pediatric nurse practitioner about melatonin. I feel like it's probably pretty safe to use forever. However, a lot of parents want to get off of it, and I don't blame them. And one thing that I always tell parents is start the melatonin and use it to jumpstart your behavioral treatment. And then you can implement, if the child is calmer, because melatonin, I should have mentioned this, doesn't only promote sleep and stabilize circadian rhythms, but it's got anti-anxiety and also over arousal mitigation. So the child who can't turn their brain off and is anxious, melatonin will help. So once that's on board, then they can learn mindfulness, they can learn other strategies that will then help them fall asleep and potentially be able to come off of the melatonin. So melatonin isn't forever, it's just jump starting your behavioral strategy. So that's another way to think of it.
It's a great point. I believe that was all of the questions. Really great questions, very complicated, but it sounds like there are lots of resources available that you'll provide us through those QR codes and otherwise. Let's see, one last question. Well, it doesn't have to be the last question. We still have time, but one question just came in. My son was falling asleep perfectly with melatonin, but then he started Depakote for absent seizures. How do we determine the next step? So melatonin was working, then Depakote was started for the seizures, and it doesn't sound like it's working as well with Depakote.
Right. Melatonin and Depakote should not interact, but you never know. It could also be the seizures are playing more of a role than we think. I would say that the first step would be to just make sure the seizures are under good control. There are some medicines that are more sedating than Depakote, and it may be that you want to use one of those medicines. If you're treating the seizures anyway, use a more sedating medicine to treat the seizures that will also help treat the sleep. That's what I would consider.
Great. Any other questions while we have Dr. Mallow here? Is there any consideration, just thinking about the Depakote, whether it's extended release or when it's given in relation to the melatonin, and if that's affecting any of that sleep cycle, that sleep wake?
In general, Depakote is pretty neutral. So I don't think of it as sedating or stimulating. So I wouldn't think so. I have a suspicion it might be the seizures more, that they're kind of maybe not completely treated yet, or something else has fallen out of whack there.
Right. We just had a sleep study, but months until we can get in to see a sleep pathologist. What is a good practice or way to incorporate learnings? And maybe perhaps you could share a little bit more in the chat. Where are you, your test results? So they just had their sleep study and they're waiting to get into a sleep pathologist. And so they are here in Atlanta, Georgia. So that could be interesting to follow up with some of our local resources as well. And do you mind mentioning how old the child is? Because I know we were talking to some of our colleagues earlier, 8 years old. Daughter. So while they're waiting to get into a sleep pathologist, sometimes there are wait lists. What are some things that maybe they could be doing in the meantime before they go in to see the sleep pathologist?
When you say sleep pathologist, do you mean like a sleep behavioralist or a sleep expert? Or I've not heard that term. I've heard speech pathologist, but not sleep pathologist.
And let's see, it's most likely a sleep expert. I'm thinking about
sleep expert. Yeah.
our colleagues.
Okay.
Well, that's what they were told through CHOA, as they're referring to them as sleep pathologists.
Okay.
That's our Children's Healthcare of Atlanta here.
So I would go to those resources that Susan, I guess, will be sending out, that those toolkits that I showed you with that slide. There's videos, there's pamphlets. I mean, even though we didn't show the pamphlet to be super successful in our work, we found the coaching to be more successful. They still can help. They can give you some tips, that the book that we mentioned. But then absolutely, you may be a great person to be in our study. You know, I know we're not going to start right away, but if needed, this is exactly what we're trying to do, is scale up what we're doing in a way that can help families.
That would be great. And we could send a few of the articles around too, because even just thinking about the family inventory of sleep habits and things that we're looking at, it may be a good reminder to no caffeine after this time period, or certain things that may help also reinforce some of that good sleep hygiene.
Absolutely. And I believe you have them. So yeah.
Yes.
Yeah.
And then grateful to hear there will be an Atlanta study branch. I'm a BCBA and have families on my caseload that need help. So please, yes, I will capture your name, and please keep us in mind as we're launching this study now. And we'd love to further talk with our local experts and enroll them as potential.
Yes. Yeah. I mean, not only are we interested in the families, we're interested in the BCBAs, we're interested in the speech,
Right.
OT. There's lots of, and I mean, to me, we said this on our advisory board meeting yesterday. I feel like you guys know autism. It's easier to teach sleep than it is to teach autism. So if you're comfortable with autism, I can teach you sleep. It's not a big deal. We can do it.
Yeah.
It's more understanding the child and the family and how to work with them with autism. That is, to me, the bigger challenge. So I think you guys would be great.
And once we're through the institutional review board, we can send out more flyers and information that will tell them more. Because I'm even thinking about the echo portion of this that's going to help support them so that they're not alone as they're implementing this, would be really good. Great. So she will reach out to us, and we will reach back out to them as well. Are there supports for parents that can be shared as well? We have neurodivergent struggles too. Oh, okay, so had to keep our own schedule, ASD and ADHD.
I
So
would
that's
say, yeah. So basically to help the parents sleep better.
yeah. And I think that's a great point. I know one of my colleagues was on here earlier. I'm not sure if they're still on, but they look at that whole package of how the child's sleep affects the parent's sleep. And I know our colleagues that we were working with more recently too. So so you've got some great resources for children and how can we improve their sleep, but are there resources for parents to improve their sleep?
Absolutely. We have not published in that, but they're out there. They're definitely out there, and lots of people have focused on parents, and uh, and we can look for some and try to get you some.
Yeah, even just thinking about our colleagues more recently on the grant that we submitted on parenting stress and how lack of sleep affects a parent's stress, and a parent's stress then affects their sleep and their child's sleep. So we will definitely gather resources and can send them out. And anybody really interested in and more specific resources, please feel free to reach out to Dr. Mallow and we can connect together to further give you resources.
Absolutely. Great questions. You guys have been
Really
great.
good questions, right? Well, wonderful. We will be in touch with them with those resources. I just want to thank you on behalf of the Atlanta Autism Consortium so much for your time and your expertise and your passion for this topic, and for Zooming in with us tonight from Vanderbilt.
You are so welcome. It was an absolute pleasure, and I'm excited to have some Atlanta families and also Atlanta BCBAs and other therapists involved in this project.
Great. Lots of thank you in the chats. Muchas gracias, Dr. Mallow. Everybody is very appreciative of you. So
Thank
that will
you.
conclude our program, and we will reach out to our Autism Atlanta community going forward for more resources, but programs that will be coming up in the next month. In February, we're actually going to be hosting a couples coaching counseling panel that will all feature autistic and non-autistic couples and coaching professionals and how they help navigate the couples. So that will be in February. Thank you. Thank you very much. Have a good rest of your night.